Welcome to Echocardiography lecture series. Learning transthoracic echocardiography requires knowledge and skills. This lecture will provide you with the necessary knowledge. Skills are obtained with practice. So let's begin. This is part 1 lecture of transthoracic echocardiography, where we're going to discuss probe maneuvering, the basic windows and views. In echocardiography, every probe has an index mark. This index mark can be a notch, an LED, or a groove, or any of this combination. The reason why we need this notch is to orient the operator to the screen. So this notch here will always be presented on the right side of the screen. This notch will be presented here. So the presentation of the notch is usually presented by a symbol or a letter depending on the vendor. So this side of the image will be always presented on the right side of the monitor. Sometimes it is flipped where you can see the symbol in the other side, but this is not the standard. The other thing is, if you can see that the image is a triangular shape and the probe is situated at the top of this triangle. So this is the probe and this is the triangle. So it means any structure closer to the top of the triangle is closer to the probe, and structure that away from the triangle or the top of the triangle is away from the probe. The probe has 3 types of maneuvering: the tilting, angulation, and rotation. Tilting maneuver is moving the probe toward the side or away from the side where the index mark is. So if we say the index mark is here, so if you move the probe to this side or to this side, we call it tilting. And if you note here that tilting is moving the beam along its long axis. And if we see it in action, like in this video here, need to play it. Yes, this video here, you're gonna see that, sometimes you have a missing piece of image. If you want to go here, then you have to tilt the probe away from the index as such, so you can see this missing part. So this is tilting. The other maneuver is angulation. Angulation is when the probe is angulated to the side. So the index mark will be somewhere here or the opposite side, but your movement will be side to side, perpendicular to the index mark. And this will move the beam sideways. The last maneuver is rotation, and rotation is simply you rotate the probe along its long axis here, and as well you're gonna rotate the beam. So you can image in one plane, and by rotating like 90 degrees you can image on the orthogonal plane. So to properly prepare the patient, we will do the following. The position is, the patient will be on his left lateral position, like here. Also, he's supporting his head with his left hand. The ECG leads has to be put in such a way that it will not interfere with the scanning area. The sonographer will be situated on the right side of the patient. And this is the usual, and sometimes if the sonographer is left-handed, the sonographer and the machine can be placed on the left side of the patient. The most important thing is to assure comfort for both patient and sonographer, because this study can be as long as 1 hour. There are 5 windows to image the heart from transthoracic view. 4 of them are standards that are used in all studies. The left parasternal window on the left side of the sternum, the apical window on the apex of the heart, the subcostal window just below the subxiphoid process here, and suprasternal window. The right parasternal is not a standard window that is used all the time, but it has its indications. The left parasternal window is usually the starting position. From this window, the following views are obtained: the parasternal long axis view, the RV inflow, RV outflow, parasternal short axis view in 4 different levels: the base, mitral level, mid level, and the apical level. The first view to obtain is the left parasternal long axis view, and it is obtained by placing the probe in the left parasternal area, the second intercostal space as a starting point, and having this index mark pointing toward the patient right shoulder here. And if no images is obtained, the probe then can be slid 1 space down. Again, if another time there is no images obtained, you can slide it further down. Sometimes the patient will have obstructive lung disease where the heart is really pushed downward, so you have to slide the probe a little bit down to get the images. But you should maintain the index mark pointing toward the patient right shoulder. So this is how a left parasternal long axis view looks like. So as we mentioned, the probe here is anterior. Anything closer to the probe is anterior. Anything away from the probe is posterior. To make sure that you get a perfect, proper long axis view, you have to see the aortic valve leaflets opening and closing. At the same time, you are seeing the mitral valve leaflets opening and closing at the same time in the same plane. So now to the structures. This is the RV outflow tract, and if you look carefully you can see the RV free wall here, the anterior wall of the RV, because the probe is anterior. And sometimes if you look carefully you can see the pericardium also. This is the interventricular septum between the LV and RV, but this is the anterior part of the interventricular septum. Usually when you see the aortic valve, at the same time you see the interventricular septum, it is the anteroseptal wall. It's the anterior part of the interventricular septum. Going back to aortic valve, you can see 2 leaflets. The leaflet closer to the RV is the right coronary cusp. The leaflet away from the RV is usually the the non-coronary cusp, but sometimes it can be the left coronary cusp. And this is the left atrium, and this is the mitral valve. If you look at the mitral valve, it has 2 leaflets. The one closer to the probe is anterior. The one away from the probe is the posterior mitral leaflet. This is the posterior LV wall, and now the new term is the infralateral LV wall. And this bright structure here is the pericardium. And also here you can see the descending aorta, and sometimes in the AV groove between the atrium and the ventricle, the atrioventricular groove, you can see a small black area which is the coronary sinus. From the previous view, the left parasternal long axis view, if you remember, the index is pointing toward the patient right shoulder here. Now you have to do infromedial angulation of the beam. It means your beam is here, now you have to move it a little bit this side. So in order to do this, you move the probe superior and lateral. You move the probe in this direction, so the beam will move infromedial. So we call it infromedial angulation of the beam, and we call it the RV inflow view. This is the RV inflow view, where you can see a long axis view of the RV inflow. RV inflow, so it means the RV filling. You have the tricuspid valve here, and this is RV. Right atrium is here, and between them is tricuspid valve. This is the anterior wall of the RV near the index mark on the right of the screen. So this leaflet is always the anterior leaflet. So we know tricuspid valve has three leaflets, the anterior, septal, and posterior. This wall here can be the inferior part of the interventricular septum, or can be the inferior RV wall. If you see part of the LV, like in this case, we can see part of the LV. The LV is here. This is the LV. So this wall is the septum, the inferior part of the septum. And this leaflet of tricuspid valve is always the septal leaflet. If you don't see part of the LV, it means this wall can be the inferior wall or can be the septal wall, and this leaflet can be either the septal leaflet or the posterior leaflet. This structure here, sometimes you see it, is the Eustachian valve, and it will always direct blood from the IVC. So the IVC is here. This is the IVC, and the Eustachian valve will direct the blood that comes from IVC. So now from the previous view, you have to go back to the left parasternal long axis view by doing superior lateral angulation, just the opposite of the previous maneuver. And then you're going to see the left parasternal long axis. Then you have to do further superior lateral angulation by pushing the probe downward and medial. So the beam here will go into this direction. So this is superior lateral angulation, which will give us the RV outflow now. It's not the inflow any longer. It's the RV outflow. This is the RV outflow view, and it is called outflow view because the blood is coming out of RV toward the pulmonary artery. So this is the RVOT or RV outflow tract, and this is the pulmonic valve, and this is the main pulmonary artery. The RV is on this side, the rest of the RV. So sometimes you can see branches of the pulmonary artery. So the branch that is directed toward the RV is the right pulmonary artery, and the branch that is away from the RV is the left pulmonary artery. From the parasternal long axis view, you need to rotate the probe 90 degrees clockwise rotation. So instead of having the index pointing toward the patient right shoulder here, now it will be pointing toward the patient left shoulder. By doing this, so the heart is somewhere like this. By doing this, now instead of cutting on the long axis of the heart, now you will cut in a short axis way of the heart. So it will be short axis cuts of the heart. Now we have 4 basic levels of short axis views. The basal view, where you can see the aortic valve in short axis, then the mitral level, the mid level, and the apical level. And how to navigate through different levels is by moving the beam toward the apex. Simply, you just move the probe to this direction. By doing that, you will move the beam to this direction toward the apex. And if you reach a point where you cannot image the apex or the mid-level properly, you might need also to shift the probe one level below. So this is the parasternal short axis view, the basal level, at the level of aortic valve. So as you can see, this is the aortic valve. This is the RV is here. This is the RA emptying into the RV, and you have the tricuspid valve here. This is the left atrium, and between LA and RA is the interatrial septum. So sometimes if there is a defect also you can see it here, and sometimes also you can see the appendage. This triangular structure here is the left atrial appendage. This is the pulmonic valve, and now we go to the aortic valve. So this is the aortic valve. You have the leaflet closer to the RV is the right coronary cusp. So this is the right coronary cusp here. And then you have to look at the interatrial septum. The leaflet closer to the interatrial septum or opposite to the interatrial septum, this one is the non-coronary cusp. And the third leaflet will be the left coronary cusp. Now from the basal level, the beam has to be angulated a little bit apically until the mitral valve leaflets are displayed. Now you can see 2 mitral valve leaflets. The leaflet closer to the probe, so the probe is here, will be the anterior mitral valve leaflet, AML. And this one here away from the probe will be the posterior mitral valve leaflet. This is the interventricular septum. So this is the LV and this is the RV cavity here. Further angulation toward the apex will show the mid-level of the LV. In mid-level of the LV, you will see pap muscle. So you have to angulate until you see 2 papillary muscle. If the LV is not a perfect circle, it means you are a little bit tilted and cutting the LV in an angle. So you have to go back and move your probe 1 intercostal space down toward the apex. Okay, so now you have 2 papillary muscle. So if this is the interventricular septum and this is the RV here, so the one here closer to the center or to the section is the medial. So we call it the posteromedial. And this one here in the lateral side away from the center is the anterolateral papillary muscle. Tilting further to the apex, then you're gonna see the short axis of the LV at the apical level. Again, if you don't see a perfect circle, you might need to move the probe one intercostal space down and toward the apex. Now going to the apical window, and in order to locate the best location to get the apical window, you have to locate the apex. And the apex is defined by the maximal outermost and lowermost pulse. So you have to feel it and put the probe in that area. And note here that the index mark is pointing outside, lateral. From this window, we can get 4 views: the apical 4-chamber view, 5-chamber view, 2-chamber view, and 3-chamber views. When doing apical views, we have to understand a term called foreshortening. So foreshortening is when the apical ultrasound beam is not cutting through the true apex, like this image here A. This is the probe and is cutting a little bit on the sideway. Here, it's not cutting in the true apex. This where it should cut, coming the true apex. So when you see your view, in order to determine if this is a true apex or not, you have to know the following criteria. A true apex is not round, like here. This is a round LV, so this is not a true apex usually. So this is a true apex here, where you can see it a bullet shape. Also, the LV at the apical level here will have a minimal longitudinal motion, if any at all. And also, it will be thin. It will not be thick like here. It will be thin, something like this. It will be the thinnest area of the ventricle. And this is how you identify the true apex without foreshortening. The problem with this image here, it is not foreshortened, but we said the probe is here. The probe should cut the LV in the middle, and as you can see, this is the apex, is not pointing toward the probe, is a little bit medial to the probe, so you have to move the probe a little bit medial to cut the true apex, like here. You see, this is the probe here, and this is the apex is pointing toward the probe. In order to obtain the apical 4-chamber view, which is the first view obtained from the apical window, you have to orient the probe in a way that the beam will be oriented and directed to the patient right shoulder here. At the same time, the index mark will be pointing toward the patient mid-axillary line. And by doing so, you will get the apical 4-chamber view as such. Let me show you the video. And this is the LV here on the right side of the monitor. This is the RV. This is the interventricular septum. And because we don't see aortic valve here, this is not the anterior part of the septum. It is the infroseptum. The mitral valve, again, the leaflet closer to the septum is the anterior leaflet. The leaflet away from the septum is the posterior leaflet. So this is posterior PML, and this is the anterior mitral leaflet here. LA is here. Sometimes you can see descending aorta located here. This is the RA, and tricuspid valve here. From the apical 4-chamber view, now we have to angulate the beam a little bit anterior toward the chest wall. So you move the probe a little bit down, so you direct the beam up or more anterior. By doing that, you will get the apical 5-chamber view, which is this one. And why it is called a 5-chamber? Because now you have a new chamber came in the view, which is the aortic valve. So this is the aortic valve. And when we see the aortic valve, now this will be the anteroseptum. And this is the LVOT, which is the left ventricular outflow tract here. And anything beyond the valve, the aortic valve, will be the ascending aorta. In order to get the apical 2-chamber view, from the apical 4-chamber view, we have to rotate the probe counterclockwise by 90 degrees. So instead of having the index mark here, pointing toward the patient axillary line, mid-axillary line, now we will have it. This is the probe here. It will be like this, and your index mark will be pointing up, and it will be shown on the right side of the monitor. So the index mark is pointing here up, and it is shown here, this side of the probe. So this is why this side of the probe will be anterior, and this side here will correspond to the inferior wall of the LV. So it is called 2-chamber view because we have 2 chambers, the LV and the atrium, the left atrium. And since this part of LV is anterior, you can see the left atrial appendage here, which is anterior, is an anterior structure, and opposite to it you can see the coronary sinus, which is an inferior structure, and this is the inferior wall of the LV. And make sure you don't see any foreshortening. Now you have to make sure that this apical 2-chamber view is appropriate and is proper one. So this is why you have to check the criteria. The apical 2-chamber criteria says that in order to get a proper 2-chamber view, or to call it a proper 2-chamber view, where this wall will be the true anterior wall and this wall is the true inferior wall, you have to see the left atrial appendage on the right side of the monitor, at the same time the coronary sinus on the left side of the monitor. Also, you should not see any papillary muscle, nothing here and nothing there. Why? Because papillary muscle does not lie in the anterior wall, it's anterolateral and inframedial, so it's not anterior and inferior. And you should not see any RV cavity. So if you see an RV motion here, so this will be the septum, because you have LV and on the other side is the RV, so this is the septum. It's not the inferior wall anymore. So in this example here on the right, you can see a papillary muscle. So it means that this is not the true anterior wall, and this is not a proper apical 2-chamber view. At the same time, you see a cavity here, which is the RV cavity. So it means this is not the inferior wall, it is the infroseptum. This one here is a proper apical 2-chamber view. Going to the apical 3-chamber view, or apical long axis. It is called apical long axis because it is similar to the parasternal long axis. Exactly, it will show the same structure, but now you are viewing from the apex, and it has a different orientation. It means it is exactly the same but a little bit rotated. One advantage of this view is the orientation of the ultrasound beam. So if you have the flow going to the LVOT here and you measure the Doppler, your ultrasound beam will be parallel to the flow. It means the angle of incidence is around 0 degrees. So you have no problem here. But if you measure it in this view here, the parasternal long axis, the flow is here through the LVOT, and your ultrasound beam is almost perpendicular to the flow. It means around 90 degrees. So cosine of 90 degrees is 0, if you remember this from the physics lecture. Otherwise, you will have exactly the same structures, where you will have the RV is here, and since you see the aortic valve here, this is the anteroseptum, and this is the infralateral wall. Also, this is the mitral valve, and the leaflet closer to the aortic valve is the anterior mitral leaflet, and the one away from the valve is the posterior mitral leaflet. Moving to the subcostal window. In subcostal window, multiple views can be obtained, and usually the first view to be obtained is the four-chamber view. In order to get this view, the patient has to be lying on his back, supine, and both knees are slightly flexed so the abdominal muscles are relaxed, and then you put the probe in the subxiphoid area in a way that the index mark is pointing toward the patient left flank, and then you orient the probe so the beam will be directed toward patient left shoulder area. By doing this, you will get the four-chamber view from the subcostal window. Sometimes you have to ask the patient to take a deep breath in order to get the heart into view. Occasionally, this window will be the best window to image the heart. And this happens usually in chronic obstructive lung disease, where you have hyperinflated lungs. Now, going to the view itself, most of the time you will see part of the liver, then the RV, the septum, and the LV, left atrium, right atrium, with the corresponding valves. So this is the four-chamber view from the subcostal window. From the subcostal window, the four-chamber view, now you have to counterclockwise rotate the probe so the index will be anterior, and by doing this you will get the short axis view. Now you have to angulate the probe to cut at different level of the heart: basal level, mid level, and apical level. This is not a mandatory view to take in all patients, but sometimes if you did not get for any reason a good short axis view in the parasternal window, you can do it from the subcostal window. Now to get the IVC view, you have first from the four-chamber view to counterclockwise the probe by 90 degrees and angulate the probe so the beam will be directed toward the patient right shoulder here, and then you will get the IVC into the view. You will see the IVC and the right atrium, and sometimes between the right atrium and IVC you will see the eustachian valve. Also, a hepatic vein can be seen emptying into the IVC. If you move the probe and angulate and tilt a little bit superiorly, you can see also the SVC. If you see the SVC here and the IVC, now you have both vena cava here. It is called the bicaval view, where you can see the SVC, IVC emptying into the right atrium. And this is the IVC in action. You can see it. It is wavy, Here it collapses in a wavy manner. It empties into a chamber, which is the right atrium, and sometimes you can see Eustachian valve, and you can see a hepatic vein emptying into the IVC. So the descending aorta is a structure that is almost in the midline. So it is more medial to the IVC near the liver on the right side. So if you angulate the beam a little bit medially, you can view the descending aorta. And if you look at the descending aorta here, you will notice that it has a pulsatile motion. These are clues to differentiate between IVC and descending aorta. So if you look at the IVC, you will notice that it has a wavy motion and it collapses in a way which is a wavy. However, the descending aorta has a pulsatile motion and it does not collapse. Another thing, if you put a color Doppler on the descending aorta, you will notice a pulsatile flow. Also, the IVC will empty into a chamber, which is the right atrium, and also you can see the Eustachian valve. Also, the IVC has a hepatic vein that empties into the IVC, but nothing empties into the descending aorta. For suprasternal window, we will remove the pillow and ask the patient to extend his neck a little bit, as well as to look a little bit to the left side. So we will have a room to place our probe in the suprasternal or above the suprasternal notch here, in a way that the index mark is pointing toward 1 o'clock position. So the center here is 12 o'clock and this is 1 o'clock position. By doing this, we will get the aortic view in a long axis manner, where we're gonna see the ascending aorta, the aortic arch, and the descending aorta, as well as the right pulmonary artery in a short axis. And this is because the right pulmonary artery is under the aortic arch as such. So whenever you image the aortic arch in a long axis, you will always see the pulmonary artery or the right pulmonary artery in a short axis, and vice versa. And this is true in all cases except for some congenital diseases. Show you now a video of the arch, where sometimes you don't see the ascending arch, the ascending aorta and the descending at the same time. It is no problem, where you can only tilt the probe a little bit sideways, so you can image the ascending aorta and the descending aorta separately and record the images separately. The structure seen here is ascending aorta, descending aorta, and the arch between them, and you can see the arch vessels. The first arch vessel is the left subclavian artery, followed by left common carotid and brachiocephalic artery. And there is important structure here where we need to know it, because sometimes it will be mistaken for aortic dissection, which is the brachiocephalic vein. From the previous image, a 90 degrees clockwise rotation of the probe, now you will image the aorta in short axis. And instead of having the aorta in long axis, now you will see it as a circle. So this is the aorta in short axis. If you see it in short axis, it means now you will see the right pulmonary artery in long axis. So usually if there is no disease, no congenital abnormality, whenever you see the aorta in an axis, the pulmonary artery or the right pulmonary artery will be in the orthogonal axis. And if you increase the depth with little bit maneuvering, and if you're lucky, you can see the left atrium and the pulmonary veins emptying into the left atrium. So you can see the left upper pulmonary vein, left lower pulmonary vein, right upper and right lower. If you look carefully into this view, it looks like a crab. This is why it is called crab view. A word on the right parasternal window. So here is the right parasternal window, and the main use here is to use this probe and this window. This is the PDOF probe or the pencil probe or the non-imaging probe, because this probe will not produce an image. It will produce a spectral Doppler, a continuous wave spectral Doppler. Why we use it? Because it has a small head where it can be easily situated in the intercostal space somewhere here and tilted up and down in a way it will be oriented with the aortic flow. So you don't see any image, but you will move it and try to orient it, so you will obtain the maximal velocity of aortic flow, and it is used in cases of aortic stenosis. So you try to sweep, you put the probe here and you sweep the probe toward the apex to get the maximal velocity. This is the end of Transthoracic Echocardiography lecture part 1. The next lecture will be about Transthoracic Echocardiography protocol. Thank you for watching.